Gastrointestinal Introduction. The primary role of the digestive tract is to extract the molecules essential for cellular function from the food and fluids that we ingest. Disorders of the digestive tract can threaten the patient's nutritional status, leading to disorders in the structure and functioning of other body systems. The digestive tract is also called the gastrointestinal tract or GI tract, and the alimentary tract, with the main parts including the mouth, pharynx, esophagus, stomach, small and large intestines, and the anus. Accessory organs such as the salivary glands, liver, gallbladder, and pancreas all aid in digestion by secreting specialized enzymes to assist in the breaking down or metabolizing of foods. The abdomen and organs are all lined with a two-layer lining called the peritoneum, and this is separated by a lubricating fluid to help prevent friction with movement. Digestion will require adequate food and fluid intake, mechanical and chemical breakdown of food, and movement of food through the digestive tract. The mouth, it participates by using those teeth to cut and grind the food. Then the salivary glands will secrete saliva. It's a watery substance that contains amylase, and this initiates the breakdown of carbohydrates. When the food bolus is swallowed, the tongue will force the food into the pharynx. This is a muscular structure that joins the mouth and the nasal passages to the esophagus. The epiglottis will cover the trachea during swallowing to help prevent food and fluids from entering the respiratory tract. From the pharynx, the food will enter the esophagus. Gravity helps, but it's not essential for the movement of food through the esophagus. Peristalsis, or a wave-like muscular contraction of the digestive tract, is what moves the food into the stomach. The stomach, which is not really very large, expands significantly when food is present. It consists of three sections: the fundus, the body, and the pylorus. Gastric secretions include renin, pepsin, hydrochloric acid, and lipase, and all of these mix with the food to help form a semi-liquid mass called chyme. The pyloric sphincter will prevent this mixture from entering the small intestine until it's properly mixed. Once it gets into the small intestine, we have chemical digestion and absorption of the nutrients. It consists of three different sections: the duodenum, the jejunum, and the ileum. Bile and pancreatic enzymes will enter the digestive tract in the duodenum and assist with breaking down of fats. Additional digestive enzymes are secreted by the mucous membrane layer of the intestine. Villi are microscopic projections lining the inner layer of the intestine, and these are what absorb the food molecules into the bloodstream. Chyme will then move into the large intestine through the ileocecal valve. The large intestine consists of the cecum, which is where the appendix is located, the ascending colon, the transverse colon, the descending colon, the sigmoid colon, and the rectum, which ends with the anus where waste will leave the body. The function of the large intestines is basically to absorb water from the chyme and eliminating the remaining solid waste in the form of feces. The salivary glands, liver, pancreas, and gallbladder are not necessarily an actual part of the digestive tract, but they play a very important part in the digestion process. The liver is the largest internal organ, and it's located in the right upper quadrant of the abdomen. There's 4 lobes and many lobules of the liver. It ingests old red blood cells, metabolizes carbohydrates, fats, proteins, and steroids, and detoxifies many harmful substances. It also produces bile and excretes it. The excess bile is stored in the gallbladder, and it breaks down fat into absorbable particles. It neutralizes chyme as it leaves the stomach and assists in the absorption of fat-soluble vitamins. The breakdown of bile is what will give feces its color. The liver also helps with glucose metabolism. Excess glucose is stored in a process called glycogenesis. If the blood glucose is low, glycogenesis is reserved, and that's called glycogenolysis. If glucose is unavailable, protein and fat are broken down for energy in a process called gluconeogenesis. With protein metabolism, the liver helps with the synthesization of proteins and clotting factors, and it also converts ammonia, which is a byproduct of amino acid metabolism, into urea. And the liver also synthesizes lipids and fatty acids. It plays a part in blood coagulation as two essential elements for coagulation, which are prothrombin and fibrinogen, are synthesized in the liver. And the liver acts as a filter and inactivates many chemicals, including medications that we ingest. Hormone metabolism, the liver helps metabolize adrenocortical hormones, estrogen, testosterone, and aldosterone. The biliary tract is made up of the gallbladder and the bile ducts, and the gallbladder is a sac-like organ that actually stores bile. Its function is to deliver bile from the liver to the duodenum. The pancreas has two functions, exocrine and endocrine. The exocrine function aids in the digestion of proteins, fats, and carbohydrates. The endocrine function is carried out by specialized cells called the islets of Langerhans. These cells produce and secrete glucagon, insulin, somatostatin, and pancreatic polypeptides. Age-related changes that we see in the digestive tract begin with the teeth that are mechanically worn down as we age. The jaw itself might be affected by osteoarthritis. We see a significant loss of taste buds with age. Xerostomia, or dry mouth, is very common. The walls of the esophagus and stomach will thin with aging, and secretions will lessen. Production of hydrochloric acid and digestive enzymes decreases. Gastric motor activity slows. There's really not any significant change in the small intestine, although some vitamin and mineral absorption abilities change. With the large intestine, we see muscle layer and mucosa atrophy. And movements of the colon contents are slower, so constipation is more common. And then, finally, the anal sphincter tone the strength will begin to decrease. As we're assessing the digestive tract, remember that RNs are required to complete the full assessment, but LPNs can help assist with data collection. So ask about any weight changes, problems eating, vomiting, heartburn, any pain, etc. Determine food allergies or intolerances, history of abdominal problems, and abdominal procedures. Ask about dietary habits, their ability to obtain and prepare food, any chemical exposures. Note skin and scleral color. Describe any caries or moisture, color, lesions in the mouth. Inspect and auscultate the abdomen prior to percussing and palpating it. And if they're complaining about abdominal bloating, you may want to measure the abdomen. And if you're planning on doing subsequent measurements, make sure that you mark the skin so you know exactly where to place the tape measure. Traditional endoscopic exams will allow for direct vision of hollow interior organs with a tube called an endoscope. The scope itself can be rigid or flexible. The physician also has the capability of cauterizing small bleeding sites, obtaining biopsies, and taking pictures. Actually, several different things. They can even use tools down the endoscope to assist with procedures. The newest type of endoscopic procedures is having the patient swallow a small camera, and there's leads that are attached to the abdomen to record the video, and of course then the patient will pass the camera. Fasting and or bowel preparation might be required to any of these scopes. The radiological studies include an upper GI series, barium swallow, air contrast procedures, CT scans, MRIs, hepatobiliary scans, abdominal ultrasounds, nuclear exams, endoscopic retrograde cholangiopancreatography, or an ERCP, which is much easier to say. The liver biopsy can be done as an open biopsy with a small incision or a needle biopsy. Due to the risk of hemorrhage, you need to be sure that you obtain a consent for a blood transfusion prior to the procedure. With the needle biopsy, a pressure dressing will be applied post-procedure and has to be monitored very closely along with the vital signs and signs of blood loss. And the other complication of a liver biopsy would be pneumothorax. So the hemorrhage has to do with the fact that the liver is an extremely vascular organ. Lab studies would include an analysis of urine, blood, stool, and tissue. And blood studies can include a CBC, albumin, liver functions, bilirubin, cancer antigens. We could also do an occult blood test where stool is placed on a special paper or card and then treated with a chemical to help determine the presence of blood. Stool studies can look for parasites, blood, fat, and bile. There's significant additional information on tests and procedures that's found on pages 789 and 790 in your textbook. Tubes can be inserted into the stomach or the intestines to generally deliver feeding or help keep the digestive tract empty. Tubes that are passed through the nose are called nasogastric, nasoduodenal, or nasoenteric tubes. The name of the tube actually depends on where the end of the tube is located in the stomach or the small intestine. There are a variety of pictures to help you visualize what we're talking about in page 791 of your textbook. Enteral tube feedings can be delivered via infusion pump or by gravity. It's very critical to confirm tube placement prior to feeding to help prevent aspiration because these tubes are very easily dislodged. Make sure that you elevate the head of the bed at least 30 degrees during the feeding and for 30 minutes post-feeding to help prevent aspiration. Gastrointestinal decompression is used to relieve or prevent distension or to allow rest of the digestive tract. This is frequently done post-operatively. Intermittent wall suction is usually applied, and we need to make sure that we apply really good oral care and monitor for skin impairment at the insertion sites because skin breakdown can happen at the nose. Make certain that you wrap a piece of tape around the tube itself and secure that to the patient's gown to help prevent accidental dislodgement. Total parenteral nutrition will deliver nutrients directly into the bloodstream, and these should be administered through a central venous catheter or a PICC line. It's usually necessary to monitor the blood glucose routinely with these and never ever administer medications through the TPN lines when TPN is infusing. Digestive tract surgery, post or preoperative care. The GI tract is usually cleansed prior to surgery to help remove some of the stool and the feces that is located in the gut and or intestines. And this can also include a liquid diet 24 hours prior to surgery and an NPO status generally about 8 hours immediately preceding the surgery. Postoperative care, of course, will include relieving pain, monitoring for complications, preventing adverse effects of mobility and anesthesia, and providing intravenous fluids and the monitoring of eyes and nose. With drug therapy, I've provided a list of commonly used drugs that are used in the digestive or for the digestive tract. This will include antacids, anti-ulcer drugs, laxatives, antidiarrheal drugs, antiemetics, antibacterial and antifungal drugs, anti-inflammatory drugs, and other classes such as vitamins, minerals, albumin, diuretics, hormones, antihypertensive agents, antispasmodics, pancreatic enzymes, and insulin. And again, there is more detailed information on these drugs in your textbook on pages 794 to 798.